On behalf of Boulder Community Health, it's my pleasure to introduce this evening's speakers. Dr. Patrick Richard, board-certified radiation oncologist, Dr. Dario Pasalic, board-certified radiation oncologist, and Dr. Austin Poole, board-certified medical oncologist and hematologist. All three of tonight's speakers care for patients at Rocky Mountain Cancer Centers. Welcome to tonight's speakers.
Thank you, Karen, and wanted to start off by thanking our colleagues and team here at Boulder Community Health for organizing this lecture series. I'm happy to be presenting to many of our patients and attendees today with my two esteemed colleagues, Dr. Pasalic and Dr. Poole. I know many of you have joined us for some of our prior lectures. This is actually the third lecture in our Prostate Cancer Summit that actually began last year, and some of those videos are archived at BCH's website, so please watch those as well. This is myself and Dr. Pasalic with some of our training credentials. We have provided in the middle of that slide there some of our phone numbers so that you can call us for a visit or to meet with one of us to further discuss your care. And this is Dr. Austin Poole, who will be presenting in a little bit with his appointment number as well. Again, this is the link for some of our previous lectures. The focus on our previous lectures was more of the workup and management of early stage, low risk and intermediate risk prostate cancer, whereas tonight we'll be presenting on some of the latest and greatest for high risk, very high risk and metastatic cancer. So if you're attending tonight and you fit more of the low risk or intermediate risk category, again, I will direct you to this link to view those prior presentations. I'd also like to promote an upcoming relevant lecture, as we'll discuss today when we talk about the side effects of treatment, how it can impact a man's sexual function and intimacy. We have a Boulder-based sex therapist, Tara Galliano, that has spent time putting together a two-part series here about how she can help our guys going through treatment maintain that function that's important to them. So please join on September 20th and October 4th. One thing we're very proud of at Rocky Mountain Cancer Center and BCH is our multidisciplinary team. This has become critically important as we assess treatment options for individual patients with prostate cancer. As we'll present today, we've seen quite an advancement in our understanding of the biology, the workup, the management of prostate cancer, and it's become imperative that we work as a team to provide evidence-based recommendations. So you can see some of our partners here at BCH, BMC, our NCORE clinical trial researchers, as well as Rocky Mountain Cancer Center. What we're also proud of is meeting twice a month for our multidisciplinary GU Oncology conference, where all of the disciplines that participate in the care of prostate cancer patients are present in one setting to prospectively review your case and your situation. This includes our pathologists that are looking at the Gleason score, the biopsy results, our radiologists that are looking at the MRIs and our PSMA PET scans, our urology colleagues that are presenting surgical options, again, our clinical trial coordinators, medical oncologists like Dr. Poole that are talking about systemic therapy, and myself and Dr. Pasalic to present radiation options. Patients really love to hear that we take this approach because their case is discussed with many different providers and we arrive at an evidence-based recommendation that we then discuss with them. Unfortunately, a lot of other systems don't focus so much on the multidisciplinary approach, and you may meet with a urologist or a radiation oncologist and basically are told what to do, but we like to, again, review all options and present that in an unbiased manner for each patient. A brief outline of what we're going to be presenting today. I'm going to start off by talking about the diagnostic tools and the risk grouping for prostate cancer. We'll transition to Dr. Pasalic and Poole to talk about some of the treatment options, whether it be radiation or systemic therapy, and I'll close us up with a discussion on some of the clinical trials we have available for our patients. So starting off with diagnosing and grouping. The reason this is important is we're trying to understand the stage and risk group for each prostate cancer case. The two main risks that we hope to address and give you a sense of is the risk of metastasis, also known as the risk of this cancer spreading to other organs such as the bone, the liver, the lung. But also prostate cancer mortality. What is the likelihood that this cancer could affect your survival? You can see on the table on the right here that prostate cancer is the second leading cause of cancer death in men, just behind lung cancer. And we see such a wide range of risk that it's very important that whatever provider you meet with goes over this and helps you understand what that risk is. These are the tools we currently use to separate a case into a certain risk category. Historically, we've used mostly clinical information. We've used the results of a Gleason score, a PSA, a prostate exam to come up with what that clinical risk is. We use a lot of imaging information, which in a few slides I'll present, whether it be an MRI or a PSMA PET scan. Two of the more recent advances have been somatic testing. This is where we get the tumor cells from the biopsy and run a genetic or genomic test on it called decipher, and we'll discuss that in a few slides. And then Dr. Poole will present some information about genetic testing. This is where we actually get a DNA specimen from the patient and figure out whether this is a genetically linked prostate cancer. And the big excitement there is we can manage that cancer potentially differently if there is a predisposing mutation. As a refresher here, this is the very wide risk spectrum that most patients with prostate cancer fall onto. Again, our prior lectures were more on the left side of that spectrum. What we're going to be presenting today is the high risk, very high risk, and metastatic. And generally speaking, this is when there's a large quantity of aggressive Gleason score, or we see signs that this cancer has escaped the capsule of the prostate gland, it's gone to lymph nodes, and in a metastatic situation, gone to a distant organ. A little bit about our staging studies. Again, it was very important once we get the biopsy results demonstrating a prostate cancer is that we understand where it's located. What does it look like in the gland? Is it in the lymph nodes? Is it somewhere else? And so one of the best tools to assess that is imaging. I'd like to run through some of the options of how we image the body to determine where the prostate cancer is. The two historical ways we've done it are with a bone scan and a CT scan. These two images are bone scans. As you can see, we're looking at the skeleton. There's no way we can look at the organs or the viscera or soft tissue. This is purely looking at the bones. It's not very specific for prostate cancer. We actually use bone scans for many other types of cancer that go to bone, because when cancer travels to bone, it tends to disrupt the appearance of it. And we could see uptake on a bone scan to suggest that something is going on there that could be related to the cancer. A CT scan helps us look at soft tissue. It looks at the entire body. We can sometimes look at the lymph nodes or the prostate gland. When you combine these two, if you see something abnormal on a CT scan, you could then look at the bone scan and see whether that's associated with some change to that bone. Again, I'm calling this an historical way because, as I'll show, we have a better tool, but this is how we've staged and worked up prostate cancer to determine the extent. MRIs are still a very common way we look at specifically the prostate gland. Here at BCH, we offer what's called a multiparametric MRI of the prostate gland. You can see the fine details of what that gland looks like. And there's a scoring system that we've typed out there called the PIRAD system that really describes what those changes are. So you go through the MRI, our radiologist looks at this image and says, you know, I see a PIRADS 3 or a PIRADS 5 lesion. Generally speaking, PIRADS 1 through 3 tend to be low grade. We're not seeing a large amount of active cancer, whereas PIRADS 4 or 5 really have some features that suggest it could be a higher Gleason grade or a more significant amount of cancer. The new kid on the block is the PSMA PET scan. The tracer for this scan was approved by the FDA in January of 2022, so we've been delivering this scan at many of our Rocky Mountain Cancer Center facilities since that time. This is a one scan. You don't have to go in for a bone scan and a CT scan. You go in for one appointment. We basically inject you with this tracer called a PSMA tracer that is more sensitive and specific for prostate cancer. Unlike our common PET scans that measure metabolic activity, this is actually, this tracer is actually binding to the surface of prostate cancer. So it's thought to be very specific that when we see aggressive prostate cancer or lots of it, you should see this light up. As you can see in that image, there's something kind of further down in the bone that would raise our suspicion for active malignancy. So my message about this is if you're seeing a provider that says, Mr. So-and-so, we're going to be sending you for a CT scan and bone scan, I would certainly ask them about your candidacy for a PSMA PET scan, as it's more likely and reliably able to detect prostate cancer in the gland or outside of the gland. At RMCC Boulder and BCH here, we've been blessed with a brand new GE PET scanner. It's got a high spatial resolution, high sensitivity. Again, there's a couple tracers we use for our PSMA PET scans. It is approved and paid for by Medicare and most commercial insurances. Again, I would ask your provider if you're a good candidate for it, and if you need these imaging tools, I would go with the PSMA PET scan. Not going to belabor all the words here on this chart, but just to let you know, there are, again, appropriate categories or candidates for PSMA PET scan. Not everybody needs it. And so we generally reserve it for unfavorable intermediate risk prostate cancer and above. If the cancer is coming back after surgery or radiation, or there's a high suspicion that we're dealing with stage 4 metastatic cancer, we would recommend a PSMA PET scan. We're blessed at RMCC to have many different imaging facilities, basically as far south as Colorado Springs, up to Longmont, that offers the PSMA PET scans. So hopefully there's if you need one of these, there's an imaging facility close to you that we can accommodate. Genomic risk. So this is where we can actually gain objective information about the cancer biology from the biopsy specimen. This is something that we feel very strongly is an important part of the risk assessment for prostate cancer. As I mentioned before, we have a lot of data that we use to group men with prostate cancer, and some of it is subjective, like the Gleason score. You know, different pathologists may grade it differently. PSAs can go up and down, but this is a little bit objective. It takes the cancer cells and runs a high-level RNA expression analysis of 22 genes that have been linked with a more risky form of prostate cancer. So it's a more personalized assessment based on the actual biopsy specimen. Over the past 5 to 10 years, this tool has been validated in a number of different settings for prostate cancer, over 30,000 men. So we have a pretty good sense as to the risk assessment and how to use this tool. I wanted to share this example of a page from that Decipher report. And the big point of it is a lot of providers are not using this in high risk and very high risk, because many of them say, well, Mr. So-and-so already has aggressive disease. I'm not going to get any additional information from this genomic test. This graph would suggest otherwise. This is the risk of metastasis, depending on the Decipher score. And the point I'd like to make is, yes, the majority, 57% or so of guys that have clinical high risk would also have genomic high risk, and it wouldn't necessarily change management. But look at this blue and yellow category. This is Decipher low risk and Decipher intermediate risk. A fair amount of patients, even with high risk Gleason 8, we'll call it disease, may actually have less of a risk of metastasis, and this could change management. So I've seen a fair share of guys that have Gleason 8, but small volume, low PSA, everything is not concordant with high risk disease, and we run this Decipher test, and lo and behold, they come back as low risk, meaning that despite the Gleason 8, this may not be a very biologically aggressive prostate cancer, and we can talk, you know, more at length about the risk and what we do to address it. To take it a step further, we compile all this information, right? We don't look at Decipher in isolation. We don't look at Gleason in isolation. We like to do what's called combined clinical genomic risk group. This is from an important publication in 2018 where they did validate it, and it was very much prognostic, even more so than the NCCN risk group, when you either downstage or upstage the risk based on a Decipher. So we take all that information, we say, well, is it Decipher low risk? Maybe it brings the risk down, or if it's Decipher high risk, it elevates it. So this is something that we discuss whenever somebody comes to meet with us. Either if they don't have a Decipher, we'll order it and then put that risk assessment in play to discuss treatment options. So I'd like to transition at this point to my partner in radiation oncology, Dr. Dario Pasalic, to cover some of the radiation treatment details. So.
Thank you for that great summary, Dr. Richard, and thank you for the kind introduction. Happy to be here tonight with you all. Wanted to switch our focus onto treatment, specifically looking at radiation therapy, systemic therapy, as well as radiopharmaceutical therapy within prostate cancer. So taking you back to this graph where we're looking at high risk and very high risk prostate cancer, there are different definitions and different groups will define things a little bit differently. But in general, high risk and very high risk are patients who have a PSA of greater than 20, have a very high primary Gleason score of 5, or have a combined Gleason score of 8 to 9 in multiple cores. And the other thing that's important is looking at imaging and some of the clinical factors such as extracapsular extension or seminal vesicle invasion, and that's where the prostate cancer is trying to spread outside of the prostate gland and invade into nearby structures. So all that will kind of put patients into a high or very high risk category. Now, when you come in for a consultation with either myself, Dr. Richard, Dr. Poole, we spend a lot of time talking about the competing risks of prostate cancer, and specifically how there are really two things that we always consider when we're treating prostate cancer. There's the local or regional risk of curing the prostate cancer within the actual prostate gland or lymph nodes. And there's the distant metastatic risk, or the risk that this spreads beyond the prostate gland, classically into things like bone, lungs, brain, and so on and so forth. And different parts of your care affect each of these risks separately. Classically, like I mentioned, distant metastatic disease, we focus on spread to bone, lung, and brain, which is why that PSMA PET scan can be really important to rule those things out. But just because your PSMA PET scan doesn't show any metastatic disease doesn't mean that you're not at risk of developing distant metastatic disease down the road. There can be a milieu of microscopic cells that are already present and in such a low quantity, such a low volume that we can't really visualize them very well through PSMA PET scan or MRI or bone scan. But that risk is still there and needs to be addressed with appropriate treatment. So this is why we will often combine local and regional therapy such as radiation and surgery with a distant therapy, a therapy that addresses the distant risks such as androgen deprivation therapy, also known as hormone therapy, androgen receptor therapy, chemotherapy, and radiopharmaceutical therapy. And it's really that distant metastatic risk that we worry about with patients because it's distant metastasis that often hurts patients. If a prostate cancer spreads to the bone, that could increase your risk of fracture. If you fracture your bone, you end up in the hospital. That leads to a surgery. That leads to rehab. And that could maybe, lead to a more sedentary life and a pneumonia. And it becomes this negative spiral and loop that we try to avoid and minimize as much as possible with our patients. As we kind of go through all the different treatment options, I think it's really, really important to keep this concept in mind. For any treatment, we want to make sure that they either improve your survival or they improve your quality of life. As we start getting more and more information on trials for different treatments for prostate cancer, they're really using different endpoints that are sometimes not as clinically meaningful. Response rate, progression-free survival. These things that are not hard endpoints, such as survival or quality of life, which I think are the most important things to consider as we progress through all the different treatment options. So here's a very, very broad overview of the treatment options for high and very high risk prostate cancer. Kind of a 20,000-foot view from our national guidelines called the National Comprehensive Cancer Network, or NCCN. As you can see here, the backbone of treatment is really EBRT, or external beam radiation therapy, in combination with hormone therapy, or ADT. That's a Category 1 recommendation. Surgery is certainly still an option. It's definitely an option on NCCN, but not quite a Category 1 recommendation. And we'll get into the reasons for that very soon. So here we are looking at radiation and androgen deprivation therapy. It's a Category 1 recommendation, and the reason why is because multiple trials have demonstrated the benefit of the combination of radiation therapy and androgen deprivation therapy to improve survival. And some men will have to be on hormone therapy for several years, anywhere from 2 to 3 years, depending on sort of your risk and other factors that go into it. Sometimes we'll add in something called aberratorone to this combination, which is a pill that you take. It's mainly meant for patients with very high-risk prostate cancer, such as node-positive disease or node-negative disease with certain risk factors. And this is based on a trial that showed an overall survival benefit with the addition of aberratorone for certain patients. So before we get into all the nitty-gritty details about additional treatments, since we were focusing so much on radiation, I wanted to just take this opportunity to clarify some of the jargon and some of the method behind the madness with radiation. So the general term for radiation is external beam radiation, or EBRT. And probably the most simple form of this is something called 3D conformal radiation therapy, or 3D CRT. And here's a diagram that kind of depicts that. This is a male pelvis, and the patient is sitting on the table. And the different beams here that we see coming from the front and the back and the sides essentially create a box that allow us to target the prostate gland in the center. And this is how we used to treat patients in the 1980s, 1990s, and was very effective, but as you can imagine, led to a lot of side effects because we're certainly over-treating some degree of the surrounding tissue. Since then, we've gotten much more sophisticated, and we started doing something called intensity modulated radiation therapy, or IMRT, where we can use multiple beams from different angles to help shape that radiation around the prostate gland and get much more sparing of the surrounding tissue. An even more advanced form of this that we have now, which is what we use at RMCC, is called volumetric modulated arc therapy. And that's a treatment that basically shapes that radiation around the prostate gland even more finely because the machine is moving around you, and there are metallic leaves within the machine itself that help to kind of shape that radiation dose very, very finely around the prostate gland. So altogether, these are all what we call conventional EBRT, or conventional external beam radiation treatments that we do Monday through Friday, once a day for anywhere from 8 to 9 weeks. It's still a regimen that I use today, for certain patients. Very effective, very minimal side effects. And in more recent years, we started doing something called hypofractionated radiation, where we can use a larger dose each day to do a shorter radiation treatment course, typically within 4 to 6 weeks. And this is also very effective. It does come with some slightly different side effects, but overall, still a very, very good option that I use often for my patients. And finally, we have something called ultra hypofractionated external beam radiation, also known as stereotactic body radiation, or SBRT. This is the kind of largest dose we can do per day in a very short time period. We can do it as short as 5 treatment sessions, typically done over the course of about 2 weeks, and it's very, very effective. Here's an example of just how radiation, IMRT, or VMAT specifically works. There's a machine that rotates around you. There are some imaging panels that can take snapshots of your anatomy. And this radiation beam that comes out of that head with those little metallic leaves changing shape and size as they move around you to help shape that radiation as perfectly to your anatomy as possible. So that's the concept behind what we call external beam radiation, or VMAT, or IMRT. And we're pretty proud of our technology at RMCC. I think we have the latest and greatest. We have a variant TrueBeam Edge with what we call a 6 degree of freedom couch. That's the couch, the table that patients sit on. We can adjust it in any direction, up, down, left, right, pitch, roll. So it really does allow us, really fine tuning of an adjustment on a day-to-day basis with your anatomy. We also have those little metallic leaves that you saw in the previous video. We have high definition versions of those that help us, again, shape that radiation dose really, really finely around your anatomy. So it's not enough to just have a great machine that can deliver radiation. You have to be really confident that you're delivering the radiation accurately each day. And so we really invested heavily in a new system called BrainLab ExactTrack Dynamic. And this system allows us to ensure your position every day on the treatment table in multiple different dimensions. As you can see here, we can track you at a real-time level on the surface using surface tracking, using thermal tracking, as well as x-rays for internal motion and changes in your anatomy. And this has many applications. One of the ones that you're seeing here is for our breast cancer patients. We can use it for our patients with prostate cancer, especially if you have what we call fiducials, or metallic markers in the prostate gland, to actually watch that motion of the prostate gland during your treatment, make adjustments as necessary. So it's a really slick system that allows us to have very high accuracy and precision on a day-to-day basis. So there's just a summary of that system that I just chatted about. Again, surface guidance, thermal guidance, X-ray guidance, which translates to real-time tracking and monitoring during treatment, and again, allows better precision and accuracy of setup and dose delivery. So now back to our regularly scheduled programming with different treatment options. I already talked about that Category 1 recommendation for our radiation and hormone therapy. Unlike low risk and intermediate risk prostate cancer, where we have a trial called the PROTECT trial that showed that whether you got radiation, whether you got surgery, the outcomes were the same. Same survival, same chance of curing the prostate cancer. We don't have a great trial that compares surgery and radiation for high-risk prostate cancer. So the reason why we have Category 1 recommendations for radiation plus androgen deprivation therapy is because we've just done a lot of trials in this space and we know that it works and it's very effective for patients. Surgery is still an option. It's a Category 2A option. And the reason why is because there's just been less, I think, investigation in this space, but also because patients after surgery are at a little bit of a higher risk of needing radiation or hormone therapy anyway. And in particular, and this is just one example, if you have lymph node positive disease, there's a trial that, for example, showed that there's improvement in mortality if you add in radiation after a lymph node positive surgery. So in that case, we're really adding to your toxicity. You're getting your surgery, you're getting radiation, and you're getting hormone therapy, and that can take quite a bit of toll on a patient in terms of side effects and quality of life. The question I often get is more better? Why not get surgery and radiation and hormone therapy? Let's just do the triple whammy. And the simple answer to that is we just don't know if it's better. There's an ongoing trial out of Scandinavia where they're looking at this question actually right now. So patients are being randomized to surgery plus or minus radiation and hormone therapy, or radiation and hormone therapy alone, and they're looking at whether or not one is superior over the other. We're not going to have those results for a while, and so in the meantime, if you have high risk or very high risk disease, radiation and hormone therapy is a very, very effective treatment modality. And again, going to that point, is more better? We know that in some cases it's actually not. We've looked at trials where we've combined radiation, hormone therapy, and chemotherapy, and a lot of those trials have shown no benefit, no survival benefit to that triple therapy. So within radiation oncology, we're always trying to push the limits. And in particular, we want to try and deliver more radiation dose with less side effects, ideally. And the reason why is because we know that prostate cancer has a dose relationship, meaning that the higher dose you can deliver, it seems like the more effective it's going to be. And so the most well-studied aspect of all this is something called low-dose rate brachytherapy, where we implant these radioactive seeds into the prostate gland permanently, and they deliver an extra dose of radiation, essentially what we call a boost. The study that looked into this is called Ascend-RT, and it randomized patients to that external beam radiation therapy, typically over the course of about 4 to 5 weeks of that, plus the LDR brachytherapy boost, or just doing the external beam radiation alone. And it followed patients. And at 10 years, it did show a benefit in terms of decreasing the rate of PSA or biochemical recurrence. But that recurrence benefit did not seem to translate to a survival benefit. And if anything, it actually decreased quality of life and side effects because the patients who got that brachytherapy boost had worse urinary toxicity long term, as you can see here. So for those reasons, I'm not a huge fan of adding brachytherapy boosts. The risk-benefit ratio does not meet the necessary criteria in my mind. But it's an interesting concept because, again, the more dose we can deliver, I think the better control we can have with that PSA. Similarly, there's something called high-dose rate brachytherapy, where instead of doing permanent seeds, we insert these temporary catheters into the prostate gland. And by inserting those catheters, we can have these little radioactive pellets that go into the prostate gland temporarily and deliver an extra boost dose. It's typically 2 outpatient procedures. It's an invasive procedure, just like the low-dose rate. And again, it's kind of like the low-dose rate. It's user-dependent. So there is going to be some variability in terms of side effects and outcomes from person to person. The thing that I'm most excited about is something called Stereotactic Boost and a flame boost, or a focal ablative micro boost. And the reason I'm excited about this is that these are emerging treatment options because you're able to deliver an extra dose, particularly to areas of the prostate gland, maybe where there are foci of active prostate cancer, and give an extra dose to those areas while protecting some of the other areas at risk, such as your urethra, your rectum, your bladder, thereby decreasing toxicity. So we can hopefully get the best of both worlds. Increase the dose to the prostate cancer, the parts that are at the highest risk, and then decrease dose to the surrounding tissue that's going to give you side effects. So stereotactic boosts are exciting in that it can be done as 2 or 3 non-invasive outpatient treatment options at the end of the external beam radiation. Unfortunately, we don't have as much evidence as we do with the brachytherapy yet, so it's still an emerging area of interest and investigation. Probably the best area of investigation and evidence so far is in what we call a focal lesion ablative microboost. And this is where during your normal course of radiation, so let's say you get 8 weeks of radiation, we can actually deliver a higher dose to a part of the prostate gland where we know that you have active prostate cancer based on your MRI, and give a higher dose to that region, but then give a lower dose to the surrounding tissue. And the idea is you can selectively boost parts of the prostate gland to ensure more dose and protection of other critical structures. So this has actually shown very, very good biochemical control or PSA control at 5 years with limited toxicity in terms of additional toxicity to the surrounding tissue. An example you can see here on the right is kind of our classic prostate cancer, prostate plan for patients where we just give a very homogeneous dose to the entire prostate gland. And on the left, you can see we give this more focused higher dose near that urethra while still protecting that urethra to make sure that we don't give you extra side effects. So all of this is a very exciting time for us as radiation oncologists, because these are the things that we're thinking about on a day-to-day basis as we're seeing you in clinic to try and figure out how can we give you the best possible outcomes while minimizing your side effects and overall just improving your quality of life. Now I'll turn it over to my esteemed colleague, Dr. Poole, who's going to go over some of the evidence for systemic therapy in metastatic disease.
Hi, everybody. Thank you so much for having me. It's always a privilege to be with Dario and Patrick, two incredibly capable and knowledgeable physicians. I am a medical oncologist, as I said, and so I deal more with the whole body. And so therefore, I'm going to focus a little bit on some updates in the treatment of metastatic prostate cancer. So in regards to, there's 2 broad categories of metastatic prostate cancer. There's so-called hormone sensitive and castration resistant. The prostate cancer cells are addicted to androgen signaling, and so just because one says castration resistant, it is still very much requires androgen signaling, and we can talk a little bit about that later on. So this is sort of a general idea about where we've come with prostate cancer, with metastatic disease in the last 100 years or so. And you can see androgen deprivation therapy, or frankly, chemical or physical castration, was around the 1941 by Huggins and Hodges. And there wasn't a ton of movement, at least in the hormone sensitive space, until the Charted study in 2015. And you can see since that time, there's been additional studies that have shown benefit when you add androgen deprivation therapy with another agent. And then most recently, the Arbutus Trial has actually combined chemotherapy with an androgen receptor blocker with androgen therapy. And this image here on the slide, it just kind of gives you a sense for all the different mechanisms of action. I think it goes back to what I was saying about androgen signaling and prostate cancer, that although men have castrate levels of testosterone circulating, eventually the prostate cancer will learn how to signal growth in the absence of testosterone flowing through someone's body. And so a drug like aberratorone, for instance, blocks one of the synthetic pathways that the prostate cancer cell can actually use to make its own testosterone. Apalutamide and enzolutamide are androgen receptor blockers, and what they basically do is block that testosterone intratumoral from interacting with the DNA and therefore causing growth. And docetaxel's chemotherapy. So it just sort of gets into cells and causes problems in the DNA and causing them to therefore die. So I think in hormone-sensitive prostate cancer, I think one of the landmark trials was the Triton trial, which was the addition of docetaxel chemotherapy to androgen deprivation therapy, and there was a improvement in survival, so there seemed to be some synergy there. I think the important thing to remember with the Triton trial was there was a delineation between so-called high-volume disease and low-volume disease, and why that's matters is now that we have other agents that we can combine with androgen deprivation therapy, we can look back and say, okay, docetaxel is not the only thing that we have. And so for men with low volume disease, I wrote high volume disease, what that entails. Maybe there's a better option. And this is kind of a little bit reflected in the Kaplan-Meier curves on the slide. So I think most recently, this was a meta-analysis of the different trials that looked at the addition of androgen deprivation therapy and chemotherapy. And I don't want to get into the weeds here, but what you can see is that it's clear in higher volume metastatic prostate cancer that the addition of docetaxel definitely does have an impact. And as Dario put so well, you want something that's gonna, is the juice worth the squeeze? And so it seems in high volume disease, certainly the addition of docetaxel is beneficial, where you can see in these low volume disease, it's not quite as helpful or as meaningful an impact. And so maybe another agent might make more sense than the addition of docetaxel. Just for some definitions there, metachronous and synchronous. Synchronous means that you present your first presentation of prostate cancer, of metastatic disease is sort of de novo, meaning you present with that. Metachronous is it occurs in a later date from your initial diagnosis. So synchronous being a higher risk category, or at least those patients, with high volume, high risk disease who had synchronous metastasis do worse than those with low volume, low risk metachronous disease. So this is this sort of most recent trial in 2022, the Arsens trial, and what it showed is that instead of just looking at androgen manipulation and blockers and pathway inhibitors with androgen deprivation therapy, it combined docetaxel chemotherapy with darolutamide, again, an androgen receptor blocker. And again, in terms of the overall patient population, you can see that there was overall survival benefit. What's important to note is that this was comparing androgen deprivation therapy and chemotherapy versus androgen deprivation therapy, chemotherapy, and darolutamide. So there wasn't a comparator that did not include chemotherapy, which may be a trial upcoming. And so anyway, the important thing is I brought up the charted data and then this most recent meta-analysis about low volume, low risk, high volume, high risk. And this is just made to show that, again, looks very complicated, but the important thing is the overall group did better from overall survival from the last slide. But you can see that patients with high volume, high risk disease, not only did they derive a benefit, but it appears that the low risk, low volume patients also benefited from the combination. And that these are the survival curves. You can see in the top right there, that data is a little immature, but if you actually look at the next slide about the development of castration-resistant disease, you can see in the top right that the low-volume disease patients were much less likely to develop castration-resistant disease, meaning disease that is no longer responsive to castration-level systemic castration-level systemic testosterone. So I just want to say the importance of that is that while CHARTED was a landmark trial, it's not plug and play, that we can't just say, well, there's CHARTED, and so I'm going to use docetaxel. That's what I'm most comfortable with, and not going to use a drug like apalutamide or darolutamide. I think CHARTED has been supplanted by Arsens. You should be getting darolutamide with docetaxel if that's the path that you should, you and your provider would pick. But we're not quite sure if the darolutamide and docetaxel together is any better than just darolutamide by itself. But the important thing is just to know that ADT with chemotherapy has been supplanted, and it's not a one size fits all strategy. So I think also an important thing that we're recognizing is this idea of BRCA-ness in prostate cancer. And so we've heard of the BRCA mutations in particular in women with breast and ovarian cancer, but it's also a driver, as you can see here, in prostate cancer. And why that's important is, as you can see at the bottom of the slide, that those patients tend to have higher risk disease. And obviously, if you can identify those patients with the germline mutation, meaning something they got from mom or dad, then you can identify a patient who's going to be at increased risk for prostate cancer and should be screened therein. BRCA-ness is sort of saying, okay, it's not BRCA, but it has features of BRCA in the way that the cell repairs its DNA, and oftentimes those patients can have their treatment directed in that direction, similar to BRCA. So this is just a study. I don't want to sort of get into the weeds, but this is just to show when we do look at metastatic prostate cancer, about 12% of them had at least one presumed pathogenic germline mutation. So the who to screen genetic landscape is changing all of the time. I think the important points is who should be germline genetic tested. Everyone with high risk prostate cancer, everyone with very high risk prostate cancer, again, even if those are localized, everyone with metastatic prostate cancer, everyone with prostate cancer and Ashkenazi Jewish heritage, and then if they also have a first-degree relative with prostate cancer. Again, these are always in flux and changing. We do genetic testing at Rocky Mountain Cancer. The reality is the cost of genetic testing, germline genetic testing, it continues to go down, and I think in the future we'll be screening a whole lot more people than we are right now. And so what's the importance of identifying a BRCA mutation? Obviously, it's important for your family members. Both men and women on your side of the family would be impacted by that diagnosis. But what's interesting is we can now drug BRCA with the medications called PARP inhibitors. And these are oral medications. What I wanted to bring up is the Triton III study. And the Triton III study, you can see here, was people who had progressed on aberratorone or enzalutamide in the castration-resistant setting were randomized to rucaparib, or the physician's treatment of choice. And you can see rucaparib in the BRCA population did much better. The ATM subgroup and other sort of BRCA-ness, BRCA-like groups didn't quite do as well, but there was a benefit in the overall treatment population. And the reason why that's important is oftentimes when someone is on aberratorone and their disease gets worse, they're switched over to another androgen manipulative drug, and you can see the outcomes, or you can take my word for it, the outcomes aren't great when you switch from aberratorone to enzalutamide and enzalutamide to aberratorone, either or. And so things like the Triton III study are very important and vital to our armamentarium for prostate cancer. In terms of what's on the horizon, there has been some studies that combine enzalutamide or aberratorone with a PARP inhibitor in the frontline castration-resistant setting. So the first treatment you get when you become castration-resistant. And while some of those have been encouraging, they were performed before we were adding androgen deprivation therapy with another agent. So meaning the patients in the enzalutamide talazoparib study did not receive ADT and aberratorone. They were just on ADT, and when they became castration resistant, received enzalutamide and talazoparib. So it's not clear that that's where the field is right now. And then everyone's excited about immunotherapy, and rightfully so. Unfortunately, immunotherapy, prostate cancer is a somewhat immunotherapy cold tumor. But there was some interesting data in the COSMIC trial. Again, I think in a lot of tumor types, it's how can we improve the response of immune therapy. And it appears, at least in this case, that the addition of a medication called cabozantinib, using that with the atezolizumab, at least in soft tissue disease, seem to have some benefit. So I didn't want you to feel like I didn't address immunotherapy. So I will now pass it back again to Dario. Thank you so much.
Thank you so much, Dr. Poole. Some really great information there. Learned a lot. Thank you. So this is one of my favorite topics because I feel very passionately about it. Does radiation therapy have a role in metastatic prostate cancer? Now, for the longest time, we felt that the answer was no, but times are changing. And this really gets down to the concept of how much metastasis, how far has it spread? And there are a lot of subtle things and a lot of unanswered questions still. And so it's a very exciting time for radiation oncologists in that regard. I think what we have to do when we talk about metastatic prostate cancer and radiation, we have to separate out treating the primary site, so the prostate gland, and treating the metastatic sites, bone, lung, brain, and so on and so forth. So let's focus on the first, treating the primary site or the prostate gland. There was an exciting trial called Stampede that was done, and it randomized patients to a standard of care, which would be hormone therapy, and then we added in radiation therapy to the primary site, not the bone metastases, not to the lymph nodes, just the prostate. And what we found was in patients with a low burden of disease, so 3 or less bony metastases, there was an improvement in overall survival with the addition of radiation. Now, this is still an area of investigation, but it was an exciting first result because it showed us that we can improve outcomes by just treating the prostate gland alone, even in metastatic prostate cancer. And one of the theories behind that is, are we able to eradicate high volume of prostate cancer cells that could potentially become resistant to hormone therapy or become castrate resistant. That's one of the leading theories, that radiation can maybe eradicate some of the high volume disease and allow the hormone therapy to continue to work and work more effectively. Some exciting trials in this space going on right now to verify and validate this data, but something that is certainly an option even now for patients who have low volume disease. This gets me to the other concept, which is there's a spectrum of metastatic prostate cancer. On the low volume side, we think about having a limited amount of metastases. There are some definitions of 5 or less, 3 or less. And then on the other spectrum is polymetastatic disease, where the prostate cancer has more than 5 metastatic sites of disease. And that's kind of where we're headed now. So instead of focusing on the prostate gland, we're focusing on those metastatic sites, so the bone, the lung, the brain. There are a couple of trials here that are interesting. One is called STOMP and ORIOLE, and the other one is called EXTEND. So the STOMP and ORIOLE trial included patients with metastatic prostate cancer, first diagnosed with just 1 to 3 metastases. They were randomized to doing nothing or doing stereotactic radiation, so those 5 or 3 or 1 session of radiation to the areas of metastatic disease. And they followed the patients. The EXTEND trial, instead of doing 1 to 3 metastases, they extended that to 1 to 5, and it randomized patients to 6 months of hormone therapy plus stereotactic radiation, or just 6 months of hormone therapy alone. And again, followed patients to see kind of what their outcomes were. With that STOMP and ORIOLE trial, what they found was there was an improvement in progression-free survival and delay to actual start of hormone therapy in these newly diagnosed patients with metastatic prostate cancer. And on average, as you can see here, the patients who got stereotactic radiation could delay that hormone therapy to about a year versus 6 months with the standard observation group. So it's exciting because delaying hormone therapy could give us more mileage out of that hormone therapy in the long run. It can also spare patients side effects and improve quality of life. The EXTEND trial also had a similar finding, which was that progression-free survival was improved. Now, remember what I said before? Overall survival, quality of life. And that's the data we're still waiting on to make sure that that the juice here is worth the squeeze. I think in some patients it already makes sense to do this, especially ones who might have other comorbidities where doing hormone therapy can be detrimental to them. So it's a case-by-case basis that we talk about at tumor board and one-on-one when you come into our clinic. Moving beyond oligometastatic prostate cancer and more into what we call polymetastatic prostate cancer, where there's more widespread metastases. There's some exciting trials and data looking at radiopharmaceutical therapy. One trial looked at the addition of something called radium-223, which is a radiopharmaceutical that we inject about once a month. And patients had to have at least 2 bone metastases and had to have been treated with chemotherapy prior to getting the Xofigo. And what that trial found was that the addition of Xofigo decreased skeletal events, and by doing so, seemed to improve overall survival. The idea is, if we can prevent a skeletal event, a fracture, that could prevent you from being hospitalized, that could prevent a surgery, that could prevent rehab, all that negative cycle, that negative feedback loop that I'd mentioned earlier. So that's an exciting option for some patients, who have metastatic prostate cancer. The other radiopharmaceutical on the market now is called Lutathera. It's based on this VISION trial, which randomized patients to lutetium-177 PSMA versus just standard of care systemic therapy. And again, the patients had to have a specific criteria in terms of chemotherapy and prior treatments. But what this trial also found was an overall survival benefit in patients with metastatic castration-resistant prostate cancer with the addition of lutetium-177 PSMA. So this is a radiopharmaceutical agent that specifically binds to those prostate cancer cells that express PSMA. So it's targeting those cells. That radioactive ligand is being absorbed into those cells, and that can then destroy those prostate cancer cells. And so it goes all over the body, and then it can target the prostate cancer cells very, very accurately. Now, to finish things off, we're gonna have Dr. Richard come back to discuss some of our exciting clinical trials at RMCC.
Thank you, Dr. Pasalic. So as I mentioned when I started off this presentation, we're very proud to offer our patients a fairly diverse clinical trial portfolio that may apply to them as they manage their prostate cancer. I want to give a shout out to our partners in this, which is Western States Cancer Research Program. And what this is a community-based research program through BCH and RMCC that gives us access and support for very large national randomized trials. So these trials we have in a number of different settings. And again, if you establish care with one of us, we'll go through our portfolio and see if there's anything that could apply to your treatment. One that we really like is called the PREDICT-RT trial. A busy slide, but I'll break it down in a sense that this is in guys with high-risk prostate cancer. What we're doing is we're looking at that decipher. We're looking at the genomic test to see whether we can tailor the use of ADT or hormone suppression in patients that may be lower risk or higher risk. So this first very top part is looking at the decipher score. So in guys that have a score less than 0.85, what we're doing is we're randomizing them to the current standard, which was just presented at 2 years. Or if they're lower risk, you're just getting a year. So basically it cuts that duration of ADT in half, potentially lessening the time that you're on it and the potential toxicity. On the flip side, if your score is above 0.85, this is a cancer we're very concerned with. You're coming in with a lot of Gleason score, very high risk decipher, and it's just the opposite. The question there is, should we be adding more, for like some of the medications that Dr. Poole just presented, like apalutamide or aberratorone? So we don't want to, we want to tailor this now to each specific cancer biology, and so this is an exciting trial that we've put a lot of patients on. Again, Dr. Pasalic just presented our current understanding of how radiation can be used in stage 4 metastatic prostate cancer. As he mentioned, it's an unanswered question, but these two trials hope to give us an answer. The first is this schematic on the left, the SWOG S1802 trial. So basically, this is starting guys off on hormone suppression. Again, they have metastatic disease. And what's unique about this, as Dr. Pasalic presented, is if you have a low burden, there's pretty good rationale to treat the prostate gland. This trial opens it up to even low, high burden, whether treating the prostate gland with radiation or surgery could present a efficacy improvement. The one we really like is the PROMETHEAN trial, which is the schematic on the right. Again, for decades, we treated metastatic cancer with hormone suppression alone, but we're understanding that potentially if somebody comes in with 5 or fewer sites, again, we can radiate those sites and maybe extend the time that they would ever need to have their testosterone suppressed. And so this trial is randomizing patients into that potential arm, which is just that SBRT to the tumors or SBRT plus an oral testosterone suppressor. And to name a few, even in other metastatic situations, if it's castrate sensitive, again, we're looking at adding additional androgen receptor inhibitors. If there's castrate resistant, as Dr. Poole presented, if there's a certain predisposition in that cancer cell to a treatment called PARP inhibitors, where it actually inhibits their ability to repair DNA damage, that could show some benefit. And then as Dr. Pasalic presented, one area of growing interest is radiopharmaceuticals. So Pluvicto is something that most of our patients ask us about because it's been very popularized in the press for good reasons. It's shown some good outcomes. The current indication for that is in patients that have attempted chemotherapy, and that's a huge limitation because a lot of patients are not well enough or don't desire to go on chemo, and so we can't give them that Pluvicto, that lutetium. These trials are very interesting is that we're trying to give this agent, this radiopharmaceutical, even before chemo, which is that PSMA-4 trial. And then we're trying to really move it up earlier in the cancer process to see if we can really get good control and good results where we don't even need chemo or need a higher level of treatment. So again, a lot of trials we have available. If you're with us, we're going to go over the full landscape of it and see if you're a candidate for it. If you're seen by an outside provider, please ask them if they have clinical trials that may benefit you. And one last slide. You know, a lot of my patients and the providers here know that I wear two lenses when I evaluate my prostate cancer patients. The first lens is obviously as a radiation oncologist, going through all the treatment options that Dr. Pasalic has presented, trying to fine tune what is best going to serve a patient. The other lens is in my interest as an integrative oncologist and a supportive care provider. I did a one-year training at the University of Michigan looking at ways we can incorporate complementary alternative naturopathic treatments to benefit our patients. And so I just wanted to highlight some of that approach. You know, we talk a lot about side effects of radiation, side effects of testosterone suppression, but I want the overarching message to be you don't have to live with those side effects. There's lots of things you can do in your lifestyle, whether it's physical activity, you know, exercise, restorative sleep, nutrition, that can actually minimize the impact long-term on your body. Bone density is something we look out for. There's good calcium, vitamin D supplements, nutrition therapy that can support the bones, weight training, weight resistance. A lot of guys on testosterone suppression are having joint aches and pains. We're very blessed in Boulder to have the BCH Center for Integrative Care that provides acupuncture. So we have 3 excellent acupuncturists that work with a lot of our cancer patients. We have a massage therapist. We have Reiki providers that really provide good physical and psychosocial support for our patients. Lifestyle medicine is very important. What is that? It's actually not using medicine at all, despite the name medicine. It's using the factors in your life, what you're eating, you know, the substances you're using, the activity you have, your sleep, your mental health, to promote overall health and potential improvement in prostate cancer progression. This important study from the University of Arizona called the CLIP study studied just that. They actually did a pretty rigorous 24-week program that they saw, despite being on ADT, which leads to weight gain and inactivity and fatigue, despite all that, those that were enrolled in a 24-week lifestyle management program had improvement in their weight circumference, their blood pressure, and overall had better success. Importantly, they measured some markers of tumor growth, tumor progression, and there was actually a downregulation in those genetic markers in the men that were in part of a lifestyle medicine program. So when you establish care with one of us, we go over all this, albeit over multiple visits. This is too much to go over at once. But I see guys 1, 2, 3 years out that have had great success with their treatment, but they're looking to get their life back. They're looking to move on and have good quality of life, and these things matter. Integrative medicine is kind of incorporating all that, looking at the holistic person. And the big things that I think matter for prostate cancer and treatment, whether it's radiation or hormone suppression, is diet and nutrition. Tons of diets out there, you know, some that are very popular, like the ketogenic diet. Honestly, we're big proponents of a good whole food plant-based diet. The Mediterranean diet is excellent. I consider that a low inflammatory diet because it has it's foods that are rich in omega-3 fatty acids and unsaturated fats that tend to produce low levels of inflammation in the body. There's certainly other supplements that have been studied, like modified citrus pectin. This is an extract from citrus fruits. It's a soluble fiber that in some very small, low-level studies have shown some potential slowing of prostate cancer progression. Again, we like to use acupuncture for hot flashes, arthralgias from low testosterone, and mind. You know, getting your mind sharp and engaged in this process is important. There's many ways to create mindfulness, whether it be meditation or yoga, and it can help support our patients throughout treatment. So that concludes the presentation today. Again, we'll have this lecture recorded and available at BCH's website, and now we'll open it up for questions.
All right. That is a lot of detail. We sure appreciate all of that from all 3 of you doctors that gave a perspective, I think, that helped round out the education on this topic tonight. So thank you very much. We do have some questions that have come in tonight, and remind the audience that now is the time to ask your questions in the chat, and we'll get to as many as we can tonight. And these are in no particular order. Do doctors currently perform both a physical exam and test PSA levels for older patients?
I think that is a bit of a controversial topic in terms of mainly in the primary care setting about who is and who is not screened for prostate cancer, who is average risk and who is high risk. And I think going into that would be beyond the scope of this lecture. I think that could probably be its own hour-long lecture in and of itself. But there has been a trend in this sort of post-PSA era of men presenting with more advanced disease. The idea of undertreatment and overtreatment will always be an issue in medicine, and it's going to be really hard for us to ferret out who should and who should not be screened, how often they should be screened. And so I think that is hopefully going to be modified by these, obviously it's genomic testing, identifying higher risk patients, as well as perhaps other data points that can help us screen patients more effectively and find men before they develop advanced cancer.
And to expand upon that, it's a very relevant topic. Along those same lines, as you're seeing your primary care physician, if it's every year, I would encourage that discussion because what's considered old. I didn't realize till I moved here that old in Boulder is not old everywhere else. I mean, we have one of the healthiest populations here, and it comes down to life expectancy. We like to bring that up in our visits is, should we treat this? How aggressively? Should you be screened? Comes down to really your life expectancy and our best estimate of that. But it comes up quite a bit. Some guys come in very disgruntled that they weren't getting their PSA checked. But it's a discussion to have with the PCP and hear their concerns as to why they may or may not want to screen you.
But if they are concerned, they can come to you for a screening?
I mean, sure. We can order. Typically we see people after they've been screened. We can order a test. And screen them, but usually the traditional route is to go through the primary care physician to get that ordered.
Okay, thank you.
I think if they wanted a nuanced discussion, I think instead of radiation oncology, meeting with a medical oncologist and talking about screening and risks and things like that, that may be also probably the best avenue as opposed to radiation oncology. So happy to see anyone to have that discussion.
Okay. How important is the NCCN Center of Excellence designation?
So there's a lot of groups out there. There's the Prostate Cancer Foundation, there's the NCCN. Those designations tend to skew mostly to larger academic centers. So those tend to focus more on larger academic centers. Smaller community practices are not necessarily being evaluated by some of these larger groups. I don't know if you all have any other suggestions or.
I think a lot of an NCCN designation doesn't always come down to the direct cancer care that they receive. There's a lot of supportive things and other things that are sort of administrative that are, while important, are also not particularly necessary on a patient on a day-to-day basis with their treatment. I also think there are some intangible things going to a large cancer center, NCCN designated cancer center. We always are open for people getting second opinions. I mean, get as many opinions and we're ready to be educated and to educate as well. But I also think that there's something intangible about being close to home. And these NCCN guidelines are there to make sure that we're all sort of collaboratively doing the best we can in the best interest of each and every cancer patient, regardless of whether they're in Butte, Montana, or New York City.
Yeah, I think as Dr. Pasalic was alluding to, there's many accrediting organizations. In Boulder here, we have the Committee on Cancer that meets quarterly and gets a surveyor that comes by and does our survey to make sure that we're meeting all of our metrics. So there's many platforms out there. I mean, how important that is, I would defer to the patient. You know, if you feel that you need to be treated at a NCCN accredited or COC accredited organization, then you have to go where you're most comfortable. But, you know, we'll say the majority of cancer centers in the U.S. are not accredited by NCCN. It's a select few, and there's some strict limitations about who gets to even apply for that and who doesn't.
Yeah, and just to mention, I mean, we were all trained at these large academic centers, these NCCN or Prostate Cancer Foundation centers, and we feel like that training has translated to us being able to deliver that radiation, that treatment closer to our community, and that's what we are really proud of, is to be able to bring that excellence to our communities and close to home. And I've even reached out to the Prostate Cancer Foundation to see if we could get our center accredited, and they say that they don't do it for smaller centers, only these large academic centers. So a little bit of bias there.
Cancel code blue. Cancel code blue.
So we did talk more about the high-risk cancer, but this particular person in the audience wanted to know the role of local therapy using cryo or RF therapy for lower risk cancer.
Yeah, so I mean, we have these guidelines, national guidelines. We have guidelines from the American Urologic Association. None of these organizations advocate for focal therapies, which is what cryoablation or HIFU or now you have the Tulsa laser. There's a lot of names for it out in the community. None of these things are being endorsed yet by these national organizations. There's a lack of data. We know that radiation, you know, for low and intermediate risk prostate cancer is very effective with minimal side effects. I'd love a comparison trial of radiation versus these focal therapies or focal therapy and surgery. If you have low risk prostate cancer, you should probably not be getting treatment at all. And you should have active surveillance. So I think anyone that's offering treatment in those settings, especially unproven treatments, should ideally be done on a clinical trial. So that's what I would look for when you're getting these evaluations, is that it's either on a clinical trial, that individual or that organization has a lot of experience doing that procedure. And again, that it's done in a multidisciplinary fashion where both the urologist, the radiation oncologist, the medical oncologist have all seen you, and they all agree, okay, yes, you should get this focal therapy. And I will almost guarantee you that most centers don't do that multidisciplinary collaboration.
Yeah, and and if your heart is telling you this is the way you need to go, then obviously you need to really get the full details on what is the risk of it recurring. And if it does recur, what are the options? I think what we've heard, and we've treated and seen patients that have had cryotherapy and HIFU and ultrasound and RFA, they're often not informed that, hey, if it comes back, your treatment may be more complicated or maybe less effective. It's often, these treatments are often posed as, a low toxicity, highly effective treatment, but if it comes back and we're asked to radiate the gland or remove the gland, it can pose some challenges. Again, I would completely agree with Dr. Pasalic. We need good randomized phase 3 data to support these treatments. They're very enticing. We understand that, but there's limitations to them.
And please watch our first lecture, because we do go over this a little bit with our urologist in the community, Dr. Siegel, who kind of goes into that as well.
Okay. So if a person does local therapy, what is the delay time to address BPH with TURP?
Yeah, no, it's a good question. It does come up. If I can expand upon what I believe this question to ask, we do see a lot of men that are interested in radiation, but have very enlarged prostate glands. One thing we do when we consult with you is, ending that don't know what a TURP is, it's a minimally invasive urologic procedure that goes through the urethra and basically clears out the portion of the prostate gland. Those that need TURP, and again, there's a whole workflow we go through to determine whether that needs to be done before radiation and with how the radiation approach would change. Generally speaking, we see about a 4-week or so delay, 4 to 6 weeks after the operation, to make sure the urethra is healed, you're urinating fine, there's no bleeding, there's no discharge, and that gives us, a little bit more comfort that we're not going to do added damage from radiation from tissue that hasn't healed up. But again, this is, only a few men actually need this. We have medications we can use to reduce the size of the gland before radiation. But specifically answering the question, I would say about a 4 to 6 week period and getting started to radiation in somebody that's had a TURP procedure.
Okay. Could you speak more about the advantages, disadvantages of photon versus proton therapies?
It's a topic that we come across very often. As you know, there's no proton therapy center in the state of Colorado. You have to travel to a different state to get that done, either Utah, Oklahoma, Texas, Arizona, California. Photons are X-rays, which, the idea is it passes in through tissue and out through tissue, whereas protons, it's a charged particle, so you can direct that beam of energy and tell it where to stop, essentially, at the center of the prostate gland, for example. The theoretical advantage is that you could potentially have less side effects, at least that's the way it's touted. There's no randomized data to support that right now. There are some single institution studies. There's actually a randomized trial going on right now at Harvard where they've randomized patients from photons versus protons. That trial, I believe, is closed. They're looking at the data now, so we might have those results in the next few years. But from an efficacy standpoint, photons versus protons, no difference in curing your prostate cancer. There's a theoretical potential benefit from a side effect standpoint, but all that data, I think, is very murky. I personally trained at a facility with proton therapy, and patients got both protons and photons there. And a lot of it just depended on personal preference. And so I would not personally, go out of my way to go to a different state just to get it, especially with the unknown pros and cons. And in fact, there is a little bit of data that sometimes protons can lead to more side effects, especially in the rectum. If the rectum positioning is not accounted for on a day-to-day basis, that can lead to sometimes higher rates of proctitis. So the conversation is quite complex, but I don't think there's a difference in outcomes that would sway me one way or the other right now.
Okay. Does the team support active surveillance for low to intermediate favorable PCA patients?
Yes.
Yeah, absolutely. That's part of the NCCN guidelines and something we address and assess for each patient. It's more of a nuanced discussion, I would say, because it's unique in that prostate cancer is one of the only cancers where we might just actively watch it, but we totally support it. In that situation, specifically for the favorable intermediate risk, I probably would advocate for a genomic decipher score to make sure we're not missing something that is biologically more aggressive than it looks on Gleason score or PSA. But absolutely, again, as I mentioned earlier, is a discussion on life expectancy. We see some guys in their 50s that really want active surveillance, and so we can do that for an extended period of time. But we also discuss what is the likelihood of needing treatment? What does that treatment look like so that they are prepared to, at some point maybe have to come off of it? But totally, the group supports it and
100%.
we discuss it, whether it's a good option for every one of our patients.
Which is, again, a great case for a multidisciplinary team, multidisciplinary discussion, patients with active surveillance. And we definitely fully support that when possible.
Good to know. For a 73-year-old guy with no family or personal history of PC, what screening tests would you recommend?
I think that gets back to the first question about who to and who not to surveil for prostate cancer. Again, I think that is sort of like the mammogram issue. I think it's very hot. There's a lot of debate, and I think a lot of personal feelings that come up in it, whether it's in people who are physicians or not. And so I think the idea of, if you were interested in this, in being screened, I think a PSA is a reasonable thing to do, but just knowing that that may not, the PSA could be normal and you could have prostate cancer, or the PSA could be abnormal and you may not have prostate cancer, and there's a lot of downstream consequences that need to be sort of brought to bear. And I think that's, again, best discussed with your primary doctor. I'm also happy to see you to discuss those things, but that is an issue in flux.
Yeah, I think, you know, a lot of patients want to know, even though it may not be a form of prostate cancer that needs immediate treatment. You see, patients are engaged. They want to know what's going on in their body. They want to know whether there's something there. It could be very well something that never impacts them. It's not this, you know, I think we're alluding to the fact that it's not necessarily whether we get a PSA, it's how we use that information. What do we do further that could impact your life? But that's why we take our multidisciplinary approach and meet with the team, is to understand what that elevated PSA could or could not represent.
Under what circumstances is radiation used to treat metastatic lesions?
Yeah, so we really look at the overall disease and, you know, where we are at. You know, is this an initial diagnosis? Is this oligometastatic? Is this polymetastatic? Is this metachronous? Is this synchronous? There's a lot of definitions and nuance that goes into it. If I had to boil it down, you know, patients with limited volume disease, which I would define as 5 or less metastatic sites of disease, would benefit from the addition of radiation therapy to some of those metastatic sites of disease. What that benefit is depends. You know, if it's in the lung, you know, that can certainly have a different benefit than if it's in the bone or if it's in the brain. So there's a lot of nuance that goes into it, and this is why it's such a complex and emerging topic that does require a lot of multidisciplinary care and collaboration, because we have to get the definition right, we have to get the staging right. A lot goes into making the right call who would benefit the most.
And that's where I would put a plug in for a medical oncologist. We have an internal medicine background, and I think the reality of this situation is that we want to treat. Cancer care is moving towards treating individuals. Okay, the NCCN guidelines are amazing and very relevant, but the whole picture is vitally important, and to have someone with an internal medicine background, with a whole picture background, I think gives the advantage of being able to add in those parts of things in a patient's history and medical history and surgical history and their emotional, psychosocial situation, allows us to be able to be more personalized in that treatment and make sure we're caring for the whole person. And that seems somewhat cliche, but every day we see when either I or someone else hasn't taken those factors into consideration, you know, that things don't go well or they do go well. And so I think having that scope, I think, is an important way of making sure that we're limiting toxicity and maximizing benefit.
Okay. What is the impact of the newer radiation technologies on side effects, such as radiation cystitis of the bladder?
Yeah, you know, I think it's a really great question. You know, specifically, we're talking about the SBRT treatments, 5 or fewer, high dose per treatment, but using our new sophisticated platform, the TrueBeam, with our ExactTrack system, we're finding, the jury's still out when you look at some of the phase 3 trials, whether that approach, because it is very focused and very accurate, but it's a very high dose per treatment, actually leads to, fewer side effects, and some studies may show an exacerbation of side effects just given the dosing and fractionation. That's one reason why we like the ExactTrack system. Is one thing we're always considering is, as radiation oncologists, we have margin of error. We want to treat the prostate gland, but we never want to miss. And so this is what we call a margin around the gland. With our ExactTrack system, we're in some cases able to shrink down that margin a bit, because we know that while that machine is working, while you're getting treatment, potentially we have such close eyes on you with our X-rays and our surface camera that our margin of error is greatly reduced. And so what that means is less margin that we have to treat around the gland, and potentially less radiation going to the bowel, the bladder, to cause things like radiation cystitis. So, I would say in summary, as a whole, SBRT, I wouldn't say that there's good data to suggest that it's less toxic than the longer regimens. Certainly it's more convenient, but the way we use it with our ExactTrack system could potentially reduce exposure to healthy organs and tissue.
Okay. How do you monitor post-treatment patients for recurrence or metastasis if metastasis is not originally present?
Yeah, I think usually actually, they're really great about following patients too. Again, two very aspirational physicians, very, very talented and knowledgeable. It's a privilege to get the chance to work with them. But I will typically see patients every 3 months or so and kind of follow their PSA. Any symptom, we go right after it and look. So a pain that may not be explained or may not go away, and so on and so forth. But I tend to follow the most men have been getting androgen therapy or androgen deprivation therapy who are seeing me, and so I will closely follow their PSA and their testosterone. And again, it's and then symptoms, exam, talking to someone, seeing what their life has been like, their medical history. So I think all of those things play into it, and that's been my general framework for following folks.
Okay, thank you. This is a fairly specific question, and then we'll have just a handful more and wrap this up. But this specific one says, maybe you covered this already, but can you speak about HIFU? This person has a small spot of prostate cancer rating 8 on the Gleason scale. They are scheduled for an HIFU.
So I think we kind of alluded to this before. That's HIFU or focal therapy. Also, similar things are cryoablation or RFA. Again, not a lot of evidence that this is this is definitely not the standard of care, especially not for a Gleason 8. I'd say that's a little bit worrisome. If this is the initial diagnosis of a prostate cancer, that would put you into a high-risk category, and I would worry that just a focal therapy could be underappreciating the extent of the disease. The way prostate cancer works is that you might see something very focal on an MRI or a PET scan, but you have these deeper roots, these microscopic cells that extend way further than you can appreciate. So focal therapy can really underdose or undertreat you. And unlike radiation, for example, where we are treating the entire gland with our radiation therapy, or surgery where you take out the entire gland. So I would say, that's would not be my standard of care, but I would certainly encourage you to seek a clinical trial and be a participant on a clinical trial if you were interested in doing a focal therapy such as HIFU.
In your presentation, you talked about several things: some natural boost, immunotherapy, integrative care, some of which you alluded that had measured tumor reduction. Is that part of how you approach this in conjunction with the medicine and the radiation therapies?
Yeah, Patrick's sort of an expert on this, but I think if you treat enough, we're pretty young looking, but if you treat enough men with prostate cancer and you don't address that, it does not go well. And we love you guys. I mean, we care about you guys. We want you to do well. And we're all for you feeling better and doing well. And the reality is that for me, at least, those strategies, and in Boulder, nothing's in moderation, but it can be in moderation. Exercise, eating right, being socially engaged, physically engaged. I think all of those things are really one of the only ways that you can get through some of these treatments, and particularly androgen deprivation. So I think it's a big part of what we do, and I think more than just sort of picking the plan, I think that's going to be a big part of what your day-to-day interaction is going to be with us, is supporting you and trying to get the best quality of life. But again, I think in all sorts of different tumor types, we see exercise improves sort of progression-free survival, Mediterranean diet for competing risks like cardiovascular disease, cerebrovascular disease, all of these things that can be impacted by the medication and otherwise. So I think it's a big part of what every medical oncologist and medical team should be discussing.
So you are measuring the results scientifically then for the results?
We're measuring results of treatment. You know, as I alluded to, an integrative approach suggests that the patient is getting a form of testosterone suppression or radiation with these other treatments. And yes, I mean, through measuring, you know, the PSA, as Dr. Poole mentioned, every 3 months, we can get a sense whether this whole program has worked. In many ways, yes, we are measuring the success of it. But a lot of these treatments, again, as I go through all this with people that are getting radiation, I highlight all the caveats. I mean, a lot of things like I presented on modified citrus pectin has been studied. It's you know, smaller studies. I don't over embellish the results of what to expect, but I discuss how it could play a part in the treatment and side effect reduction. So yeah, we're cognizant of the limitations of some of these approaches, but do feel that it benefits our patients.
There's the integrative tumor board as well.
Yeah, I mean, every month I conduct a integrative oncology cancer conference, which I've presented a lot of my prostate cancer patients. It's the first week of every month, where I get together with a lot of the providers at our Center for Integrative Care. They do acupuncture. I have a nutritionist, a naturopathic oncologist that joins us, and just like we do for, you know, surgery, radiation, hormone suppression, I do for the integrative treatment, so we can see what the patient's goals are, what they're interested in doing, so that we can discuss the evidence or lack thereof, and then present a full integrative approach for each patient. Okay.
So you had mentioned the defect in the DNA BRAC mutation. Can the DNA be enhanced or repaired? Is there any research going on with that?
Yeah, and so that's a good question. Yeah, I think the field of longevity sort of science is interesting. I don't know how, I'm not aware, I'm not aware of anything right now that can sort of alter the biology of someone who has a defective DNA repair mechanism, if that makes sense. I think there are people that are looking at things like elephants, and that they have this plethora of DNA repair proteins. and whether or not that could be integrated into humans. For instance, the human equivalent of a missing TP53 would be Li-Fraumeni syndrome. And so I think these things are being explored about sort of turning on tumor suppressors and turning on repair pathways. But that is not something I'm aware of that's of clinical significance or clinical or that there's anything beyond just sort of eating well and exercising and so on and so forth. So I don't think there's anything that we can bring to bear right now on that.
Okay, thank you.